This is Human Gross Anatomy Module number 15. This module covers the abdominal pelvic cavity, the gross anatomy of the foregut, midgut, and the hindgut regions. By the end of this presentation, the student should be able to define the quadrants and regions and the principal abdominal organs associated with each quadrant and region. The student should also be able to describe and define the boundaries, the content, and the in situ relationships of the viscera of the abdominal pelvic cavity, including peritoneal reflections and folds, mesenteries, and recesses. Also, the student should be able to describe the gross anatomy of the foregut, midgut, and hindgut, and should include in this discussion their component parts, neurovascular supply, and lymphatic drainage. And finally, the student should be able to explain the clinical presentation of hiatal hernias, small bowel obstruction, intestinal ischemia, appendicitis, diverticulosis, and associated referred pain. Let us begin our discussion with a clinical scenario that we can keep in mind as we learn the material contained within this presentation. Let us begin. You are the physician. Can you do it? A 53-year-old African American male patient presents to your office with the chief complaint of abdominal pain. You order the radiograph shown. You would most likely expect the clinical presentation of this patient to include A. Left testicular varicocele, B. Right testicular varicocele, C. Fever, abdominal pain, abdominal tenderness, and frequent forceful bowel movements, in other words, the signs and symptoms of intestinal ischemia, D. Caput medusae, or E. Decreased blood flow to the right kidney and hypertension. The clinical quadrants and regions were covered in Human Gross Anatomy Module number 1. Therefore, they will only be briefly reviewed here. Let's look at the quadrants first. They are formed by the intersecting planes, the mid-sagittal plane and the transverse plane. So we have the left and right upper quadrants and the left and right lower quadrants where the planes intersect at the level of the umbilicus. Then we have 9 clinical regions. These are created by 2 horizontal planes, one across the superior aspect of the iliac crest and the other across the inferior aspect of the thoracic cage, and 2 perpendicular planes that are really the midclavicular lines. These clinical regions include the umbilical region, the epigastric region or epigastrum, the hypogastric region or the hypogastrum, the left lumbar and the right lumbar, the left hypochondriac and the right hypochondriac, and the left and right inguinal regions. The charts associated with the figures here show you which organs and portions of which organs are associated with each clinical quadrant and clinical region. I encourage you to take a moment and review these tables. The abdominal pelvic cavity is a large cavity on the ventral aspect of the body that is really subdivided into 2 cavities, the abdominal cavity and the pelvic cavity. It contains the stomach, liver, pancreas, spleen, gallbladder, kidneys, most of the small and large intestine, the urinary bladder, as well as the internal components of the reproductive organs. The abdominal pelvic cavity is also lined by peritoneum, and it contains the peritoneal cavity. Peritoneum is a transparent serous membrane. It consists of a thin layer of squamous simple squamous epithelial cells, and it lines the abdominal pelvic cavity as well as investing the viscera. Peritoneum consists of two continuous layers: the parietal peritoneum that lines the internal surface of the abdominal pelvic wall, and this layer has the same blood and lymphatic supply as well as the nerve supply of the region of the wall that it lines. Then there's the second layer, the visceral peritoneum. This is the layer that invests the viscera. It has the same blood, lymphatic vasculature, and visceral nerve supply that supplies the organ. It is insensitive to touch, heat, and cold, as well as laceration, but it is primarily stimulated by stretching and chemical irritation. The peritoneal cavity, then, is the potential cavity or space between the parietal peritoneum and the visceral peritoneum. Technically, it contains no organs, but it does contain a thin film of fluid, and it is contained within the abdominal cavity. Looking at our figure, we have parietal peritoneum lining the abdominal pelvic wall, and the visceral peritoneum lining the organs. Again, the potential space in between is the peritoneal cavity, and it contains a thin film of fluid, but the cavity itself is within the abdominal cavity. The viscera are covered by the peritoneum in different ways. Some organs are completely covered by visceral peritoneum, such that the organ is invaginated into a closed type of sac. These organs are said to be intraperitoneal organs and include the stomach, the first part of the duodenum, jejunum, ileum, and cecum, the appendix, transverse colon, the liver and gallbladder, the tail of the pancreas, and the spleen. Other viscera are only partly covered by the peritoneum, usually on one surface, and therefore they are really external to the parietal peritoneum. This can make them either extraperitoneal, retroperitoneal, where they are actually posterior to the abdominal wall, and subperitoneal, means that they are beneath the peritoneum, where the parietal peritoneum is only on the organ's superior surface. These structures include, respectively, portions 2, 3, and 4 of the duodenum, the ascending and descending colons, as well as the rectum, the head, neck, and body of the pancreas, kidneys and ureters, adrenal glands, the abdominal aorta, and the IVC as being considered extraperitoneal, the kidneys, which are retroperitoneal, and subperitoneal, such as the urinary bladder and the uterus. The visceral and parietal peritoneum not only line the organs and the abdominal wall respectively, but they create folds and gutters, etc. Anatomists give terms to describe these various folds and gutters within the abdomen. The most common is the term mesentery, which is a double layer of peritoneum, and it results from the invagination of the peritoneum by an organ, and therefore it constitutes a continuous or continuity of the visceral and parietal peritoneum. It provides for a neurovascular communication between the organ and the body wall, and it connects the intraperitoneal organ to the body wall, usually the posterior body wall. Typically, the small intestine mesentery is simply referred to as the mesentery. Mesenteries related to other specific parts of the GI tract are named accordingly. For example, the transverse mesocolon for the transverse colon, sigmoid colon, that mesentery going to and from the sigmoid colon, mesoesophagus, that mesentery going to and from the esophagus, mesogastrum, the mesentery to and from the stomach, and the mesoappendix, that mesentery to and from the appendix. Even so, some mesenteries are quite large or contain very important structures, and therefore they are given special names. One of these names is omentum. Omentum refers to a double layered extension of peritoneum, and this peritoneum passes from the stomach to the proximal part of the duodenum to adjacent organs in the abdominal cavity. Two large omenta exist, the greater omentum and the lesser omentum. The greater omentum is a four-layered fold that hangs down like an apron from the greater curvature of the stomach in the proximal part of the duodenum. It descends in the abdomen and folds back and then attaches over the anterior surface of the transverse colon and its mesentery. This is in contrast to the lesser omentum, which is a double layer peritoneal fold that connects the lesser curvature of the stomach to the liver and duodenum. It also contains a triad of structures that run between the duodenum and the liver in its free edge, located by the laser pointer. This opening along the free edge is referred to as the epiploic foramen or the foramen of Winslow, and it contains the portal triad, hepatic artery, bile duct, and the hepatic portal vein. The thickening in this area is known as the hepatoduodenal ligament. Therefore, thickenings that contain various structures are referred to as peritoneal ligaments. These are also double layered of peritoneum, and they connect an organ with another organ or to the abdominal wall. For example, the liver is connected to the anterior abdominal wall by the falciform ligament, to the stomach by the hepatogastric ligament, and to the duodenum by the hepatoduodenal ligament. These are continuous parts of the lesser omentum. Let us look at some other peritoneal ligaments. For example, the gastrophrenic ligament. This ligament connects the stomach, gastro, to the diaphragm phrenic, gastrophrenic ligament. The gastrosplenic ligament connects the spleen to the stomach, and it reflects onto the hilum of the spleen, that groove on its medial surface where vessels and other structures enter and exit the organ, gastrosplenic ligament. Then there's the gastrocolic ligament, which is actually part of that apron-like greater omentum. The gastrocolic ligament descends from the greater curvature of the stomach and ascends to the transverse colon, so it connects the stomach with the transverse colon, gastrocolic ligament. Still, there are also reflections of peritoneum that are raised by structures underlying or within the body wall. These result in peritoneal folds. These folds include the umbilical folds on the internal surface of the abdominal wall, actually the anterior lateral abdominal wall, seen in the diagram here at the right. Here we have the median umbilical fold, the medial umbilical fold, and the lateral umbilical fold. The umbilical folds are on the internal surface. The lateral umbilical folds contain the inferior epigastric arteries. Peritoneal recesses or fossa are also formed. These are basically pouches or recesses of peritoneum, and these are formed by a fold. They form on either side of the fold, such as the inferior recess of the omental bursa, the supravesicular fossa, and the umbilical fossa. These are between the umbilical folds. You can also have pericolic gutters that form by the folds of peritoneum on the lateral aspects of the ascending and descending colons respectively. These folds and continuities of peritoneum also help to create subdivisions within the peritoneal cavity. These subdivisions include the greater peritoneal sac and the lesser peritoneal sac. The greater sac is the main and larger part of the peritoneal cavity. A surgical incision through the anterior abdominal wall or the anterior lateral abdominal wall enters the greater sac. The lesser peritoneal sac is really referred to as the omental bursa or lesser sac. It lies posterior to the stomach and the lesser omentum. Then we have the transverse mesocolon. It divides the abdominal cavity into the supracolic compartment. Here's the transverse mesocolon on the right. So it divides the cavity into a supracolic compartment above and an infracolic compartment below. The supracolic compartment would contain the stomach, the liver, and the spleen, or the foregut organs. The infracolic compartment would contain the small intestine, ascending and descending colon, and it lies posterior to the greater omentum. Further, it is divided into the left and right infracolic spaces by the mesentery of the small intestine. There is free communication between the supracolic and infracolic compartments through paracolic gutters. These are grooves on the lateral aspect of the ascending or descending colon and the posterior lateral abdominal wall. These grooves are created by folds of parietal peritoneum. The omental bursa is a sac-like cavity, and it lies directly posterior to the stomach, the lesser omentum, and adjacent structures. Here we outline it in blue and using the diagram at the right. It is a superior recess that's limited by the diaphragm and posterior layers of the coronary ligament of the liver. Its inferior recess is limited, or actually between the superior parts of the layers of the greater omentum. It permits free movement of the stomach on structures posterior and inferior to it, and most of the inferior recess of the bursa becomes sealed off from the main part posterior to the stomach after adhesion of the anterior and posterior layers of the greater omentum. This omental bursa has various communications and boundaries. It communicates with the greater sac through the omental foramen, the epiploic foramen, also referred to as the foramen of Winslow. Here the physician is inserting his fingers through the omental or epiploic foramen. Its boundaries include anteriorly the hepatoduodenal ligament. This is the free edge of the lesser omentum, and it contains the hepatic portal vein, the hepatic artery, and the bile duct. Posteriorly, its border includes the inferior vena cava and a muscular band, or the right crux of the diaphragm. Superiorly, it is bordered by the liver and covered with visceral peritoneum, and inferiorly, its border is the superior or first part of the duodenum. Now let's discuss some general things about the abdominal viscera. Then we'll look at each organ separately and discuss its gross anatomy as well as its anatomical relationships. The abdominal viscera include the terminal part of the esophagus, the stomach and intestines, the spleen, the pancreas, the liver and gallbladder, kidneys, and suprarenal or adrenal glands. The kidneys and the adrenal glands will be covered in a separate module. Looking at the abdominal organs pictured in the diagram at the right, we can see that the liver, the stomach, and the spleen fill most of the domes of the diaphragm. The liver on the right, and liver, stomach, and spleen on the left. The falciform ligament attaches the superior part of the liver to the inferior part of the diaphragm, and it extends as far inferiorly as the umbilicus. It divides the liver superficially into left and right lobes, and the gallbladder, of course, projects inferior to the border of the liver. The greater omentum conceals all of the intestine, or almost all of it. You can see a few loops here. Peristalsis is a series of contractile waves that begins in the midline of the stomach and moves slowly toward the pylorus. It is responsible for moving masticated food and gastric juices toward the duodenum. Once in the duodenum, the absorption process begins, partially, but digestion also continues. Most of the absorption of food nutrients takes place in the jejunum, the second part of the small intestine, and the third part is the ileum, where mostly water is absorbed. Then we have the large intestine, consisting of cecum, ascending and transverse colons, descending colon, sigmoid colon, rectum, and then, of course, the anal canal. It also has some folds in it, such as the left or splenic flexure and the right or hepatic flexure. The main function of the large colon is the reabsorption of water that occurs as the luminal contents is pushed through. This results in the creation of feces. The esophagus, stomach, the small and large intestines constitute the gastrointestinal tract, or the GIT, and it is derived from the primordial foregut, midgut, and hindgut. The vascular supply of the abdominal organs also has a pattern to it. For example, the arterial supply is all derived from the abdominal aorta. Even more specifically, there are three main branches involved: the celiac trunk, the superior mesenteric artery, or SMA, and the inferior mesenteric artery, or IMA. The celiac trunk, for the most part, supplies organs derived from the embryonic foregut. The superior mesenteric artery supplies those organs derived from the embryonic midgut, whereas the inferior mesenteric artery, or IMA, supplies mostly those organs derived from the embryonic hindgut. The venous system also has a pattern to it. The main vein is the hepatic portal vein, and it is formed by the union of the splenic and superior mesenteric veins. It collects blood from the abdominal part of the alimentary or GI tract, as well as the pancreas, spleen, and most of the gallbladder. Blood is returned to the liver, where it is filtered before it's returned to the venous circulation. Now let's begin to look at some specific organs. And the first that we will look at is the esophagus, which is basically a hollow muscular tube that extends from the pharynx or throat to the cardiac region of the stomach. It normally has three constrictions in it, where it comes in contact with adjacent structures. This includes the cervical constriction, the thoracic constriction or the bronchial aortic constriction, and the diaphragmatic constriction. The cervical constriction is also known as the upper esophageal sphincter. It begins at the pharyngo-esophageal junction, which is approximately 15 centimeters from the incisor teeth, and is caused by the cricopharyngeus muscle, right about here in our diagram. Then there's the thoracic or bronchial aortic constriction. Here it is in the barium meal film shown above, okay, and the site of the thoracic constriction in the diagram below. It's a compound constriction where the esophagus is first crossed by the arch of the aorta and then by the left main bronchus. And finally, we have the third constriction, the diaphragmatic constriction, which is where the esophagus passes through the esophageal hiatus of the diaphragm. Anatomically, the esophagus follows the curve of the vertebral column as it descends from the neck and through the mediastinum. It is composed of an inner circular layer and an external longitudinal layer of muscle. The superior third of the external layer consists of voluntary striated muscle. The remainder is smooth muscle and a combination made of both types. It passes through the esophageal hiatus, right near or through the muscular right crux of the diaphragm. This is just left of the median plane at the level of the T10 vertebra. So, at level T10, the esophagus penetrates the diaphragm at the esophageal hiatus. It's a good reference level to keep in mind. It is attached to the margins of the hiatus in the diaphragm by the phrenicoesophageal ligament. This permits independent movement of the diaphragm and the esophagus during respiration and or swallowing. It terminates by entering the stomach at the cardial orifice. You can see this here at the right. This is just to the left of midline and at the level of the 7th left intercostal cartilage and the 11th thoracic vertebra. The junction is called the esophageal gastrojunction, and it lies to the left of T11 on a horizontal plane that passes through the tip of the xiphoid process. This plane is referred to as the Z line. Here it is, the esophageal gastrojunction. It is encircled by the esophageal nerve plexus. Because the esophagus is considered a derivative of the foregut, it will be supplied by the first major branch of the abdominal aorta, or the celiac trunk. Its branches include the left gastric and the left inferior phrenic artery. The venous drainage is taken away by the azygos system of veins via smaller esophageal veins, and the portal venous system by way of the left gastric vein. The left gastric drains into the splenic vein, which unites with the superior mesenteric vein to form the hepatic portal vein. The esophagus receives both a parasympathetic and a sympathetic nerve supply. The parasympathetic supply is derived from an esophageal plexus to which the left and right vagal trunks contribute. It becomes anterior and posterior gastric branches that go over the stomach. The sympathetic component is from the thoracic sympathetic trunk. Fibers pass through the greater splanchnic nerve and into the periarterial nerve plexuses, as well as the celiac ganglion. The plexuses surround the left gastric artery and the inferior phrenic artery. The lymphatics include those from the stomach and the esophagus that drain into the celiac nodes. Lymphatic drainage of the abdominal part of the esophagus is into the left gastric lymph nodes, and efferent lymphatic vessels from these nodes drain mainly into the celiac lymph nodes. Now let's look at the stomach. For the most part, it's contained in the left upper quadrant. In terms of clinical regions, we have the left hypochondriac, left umbilical, or at least the upper portion of that, and the epigastric region. It has a cardiac or cardia region, a fundus, a body along the graded curvature, a pylorus with an antrum and canal. The cardia region contains the inlet for the esophagus, and it's separated from the fundus by a cardinal notch. The fundus is the dilated superior portion that creates the left dome of the diaphragm. The body is the major portion of the stomach. It is between the fundus and the pyloric antrum and composes both the lesser and greater curvatures. The pyloric part is really the outflow region. It has a wide part, the pyloric antrum, through which the food is directed toward the pyloric canal, and a distal sphincter region of thick circular bands of smooth muscle. Normally, this sphincter is contracted so that the pyloric orifice is reduced in diameter. As the flow of chyme goes through the stomach, the sphincter allows chyme to slip through the mixture of nutrients and digestive juices through gastric peristalsis, and it's pushed through into the duodenum. The transpyloric plane is a plane here shown in the lower right diagram. It is known as Addison's plane, and it's located halfway between the jugular notch and the upper border of the symphysis pubis. In the supine position, the pyloric part of the stomach falls at the level of this plane, and the pyloric orifice is about 1.25 centimeters to the right of midline in this plane. The stomach also has a lesser curvature and a greater curvature. Again, here's the lesser curvature and the greater curvature. The lesser curvature is shorter and concave, and it constitutes the right border of the stomach. It has an angular or incisure notch. It is the most inferior part of the curvature. The greater curvature forms the longer, convex left border of the stomach, and it passes inferiorly to the left of the junction of the fifth intercostal space and the midclavicular line. It curves to the right, passing deep to the ninth or 10th left costal cartilage as it continues medially to approach the pyloric antrum. Because the lengths of the lesser and greater curvatures differ, the stomach takes the shape of the letter J. The internal surface is a smooth gastric mucosa covered by a mucus layer that protects it from gastric acid. When contracted, the gastric mucosa is thrown into longitudinal ridges or folds. These gastric folds are also known as rugae. During swallowing or gastric emptying, temporary canals are formed through these rugae that help move the quantities of masticated food mixed with digestive juices toward the pyloric antrum. There are also several anatomical relationships for which the physician should be aware relative to the stomach. First, the stomach is covered by visceral peritoneum, except where blood vessels run along its curvatures, the greater and lesser curvatures, and a small area posterior to the cardiac orifice. The two layers of the lesser omentum extend around the stomach and leave its greater curvature as the greater omentum. Anterior to the stomach is related to the diaphragm, the left lobe of the liver, and the anterior abdominal wall. Posteriorly, the stomach is related to the omental bursa and the pancreas, and the posterior surface of the stomach forms most of the anterior wall of the omental bursa. The transverse colon is related inferiorly. Here it is at the right. It courses along the greater curvature of the stomach and toward the left colic flexure. The bed of the stomach, on which the stomach rests in supine position, is formed by structures of the posterior wall of the omental bursa. These include the left dome of the diaphragm, the spleen, the kidney, as well as the adrenal gland. Recall that the stomach is one of the organs derived from the foregut, and therefore it is going to be supplied by the celiac trunk. Here's the celiac trunk, giving rise to the left gastric artery with its esophageal branch, and that artery curves around along through the lesser curvature of the stomach, joining with the right gastric artery. The right gastric artery arises from the common hepatic artery, another branch of the celiac trunk. The splenic artery is another major branch from the celiac trunk, and it runs posteriorly along the stomach and the posterior part of the pancreas. It gives rise to the left gastro-omental or epiploic artery running along the greater curvature of the stomach. It unites with the right gastro-omental or epiploic artery, whose origin is the gastroduodenal artery coming off of the common hepatic artery. Here's a table that reviews the arteries that supply the foregut organs. You should take some time and review this table. The main venous drainage of the stomach is the hepatic portal vein, seen here in the diagram at the right. It's formed by the union of the superior mesenteric vein and the splenic vein running along the posterior part of the body of the pancreas. Its feeders include the left gastric vein along the lesser curvature of the stomach and the right gastric vein, as well as the pre-pyloric vein. The pre-pyloric vein is important because it ascends along the curvature of the pylorus and therefore can be used as a landmark for identifying the pyloric region of the stomach. Feeding into the splenic vein is also the left gastro-omental or epiploic vein along the greater curvature of the stomach, and its sister component, the right gastro-omental vein, which is going to feed into the superior mesenteric vein. Again, the superior mesenteric vein and the splenic vein unite to form the hepatic portal vein. You can see from the diagram at the right that the lymphatics of the stomach are very complex. Gastric lymphatic vessels in general accompany the arteries along the greater and lesser curvatures of the stomach, and they drain from its anterior and posterior surfaces toward the curvatures. At these curvatures are located nodes, such as the gastro-omental lymph nodes. Then efferent vessels accompany the large arteries to the celiac lymph nodes. Briefly, lymph from the superior two-thirds of the stomach drains along the left and right gastric vessels to the gastric lymph nodes. Lymph from the fundus and superior part of the body drains along the short gastric arteries and omental vessels to the pancreatico-splenic lymph nodes, and lymph from the right two-thirds of the inferior third of the stomach drain along gastro-omental vessels to the pyloric nodes. Lymph from the left one-third of the greater curvature drains to the pancreatico-duodenal lymph nodes. These are located along the short gastric and splenic arteries. The stomach receives both a parasympathetic and a sympathetic nerve supply. The parasympathetic component is created by a continuation of the esophageal plexus around the stomach via the anterior and posterior vagal trunks. The anterior vagal trunk usually enters the abdomen as a single branch, and it lies on the anterior surface of the esophagus. It will run toward the lesser curvature of the stomach. There it will give off hepatic and duodenal branches. The remainder of the anterior vagal trunk continues along the lesser curvature, giving rise to anterior gastric branches. The posterior vagal trunk is larger, okay, and it's derived mainly from the right vagus nerve. It enters the abdomen on the posterior surface, and it passes through the lesser curvature of the stomach and supplies branches to the anterior and posterior surface of the stomach. It gives off a celiac branch, which passes to the celiac plexus and then continues along the lesser curvature of the stomach. It gives rise to posterior gastric branches. The sympathetic component arises from the T6 to T9 segments of the spinal cord, or the IML. Fibers enter the greater splanchnic nerve and pass through the celiac plexus or celiac ganglion. Then the postsynaptic fiber is distributed to the plexus around the gastric and gastroomental arteries. The small intestine consists of three sections: the duodenum, the jejunum, and the ileum. We are going to focus on the first portion, the duodenum, and the duodenum itself also consists of four different parts. For its entire length, it is the shortest part of the small intestine, but it is the widest and is the most fixed part of the small intestine. It has a C shape that sort of cups the head of the pancreas. And it begins at the pylorus and ends at the junction on the left side between the duodenum and the jejunum. It's considered partly retroperitoneal, and it forms an acute angle known as the duodenal-jejunal flexure at its union or junction with the jejunum. The duodenum can be divided into four portions or regions: a superior, a descending, an inferior, and an ascending. Here's the pancreas, okay, and the duodenum. So this is an anterior view. Okay, here's the posterior view. So here's the duodenum and the pancreas. And our regions are numbered 1, 2, 3, 4. Reversed here because of the posterior view, 1, 2, 3, 4. So the first region is the superior region, and it is short and it is within the peritoneum. Okay? It has a mesentery that's mobile, so this is the free part, or the ampulla or cap. Okay? It has a proximal part that has the hepatoduodenal ligament, which is part of the lesser omentum, and the greater omentum also attaches inferiorly. The descending part, region number 2, okay, descends along the right sides of L1 through L3. The bile and main pancreatic ducts enter this region. They usually unite to form the hepatopancreatic ampulla, which opens on an eminence within the lumen of the small intestine, known as the major duodenal papilla. The inferiormost portion is the third portion. It's about 8 centimeters long, and it runs transversely, passing over the inferior vena cava, the aorta, and the L3 vertebra. And lastly is the fourth region. It ascends, okay? And it is retroperitoneal, just like the descending and inferior regions. The ascending region is short. It begins at the level of L3 and passes as far as the superior border of L2, and it is supported by an attachment of a suspensory muscle of the duodenum. This is known as the ligament of Treitz. Here are the anatomical relationships just discussed in the prior slide of the regions, or four divisions, of the duodenum, and the structures and levels that they pass over. Also, on this cut region here, you can see the major duodenal papilla as well as hepatopancreatic ampulla. The duodenum is a derivative of the foregut and therefore is supplied by the celiac trunk, as well as other foregut structures. Here you can see the celiac trunk from the posterior perspective. It's the first main branch off the abdominal aorta. It will give rise to the gastroduodenal artery, and the gastroduodenal artery in turn will give rise to the anterior superior pancreatical duodenal artery and the posterior superior pancreatical duodenal artery. The superior mesenteric artery, the second major branch off the abdominal aorta, gives rise to the inferior pancreatical duodenal artery, which also branches into anterior and posterior components and will anastomose with the superior components around the duodenum. So if we look at our diagram at the right, here's our anterior superior pancreatic duodenal artery, right gastroduodenal artery, coming back from the celiac trunk. This down here would be the superior mesenteric, from behind, superior mesenteric artery. The venous drainage again is by the hepatic portal vein, which is formed by the union of the splenic vein and the superior mesenteric vein. The superior pancreatical duodenal veins drain into the splenic, whereas the inferior pancreatical duodenal veins drain into the superior mesenteric. As usual, the lymphatics follow the arteries, so the anterior lymphatic vessels will drain into the pancreatical duodenal lymph nodes, the pyloric lymph nodes, and the posterior lymphatic vessels will pass posterior to the head of the pancreas and drain into the superior mesenteric lymph nodes. Efferent lymphatic vessels from the duodenal lymph nodes drain into the celiac lymph nodes. Innervation is derived from the vagus nerve through the greater and lesser splanchnic nerves via the celiac and superior mesenteric plexuses. Have the respective associations between the greater splanchnic nerve and the celiac plexus and the lesser splanchnic nerve and the superior mesenteric plexus. Vagus transfers parasympathetic innervation, whereas the splanchnic innervation will supply sympathetic fibers. The second and third part of the small intestine include the jejunum and then the ileum. The jejunum begins at the duodenal jejunal flexure, where the gastrointestinal tract resumes an intraperitoneal course. Therefore, most of it lies in the left upper quadrant. Or we can say the infracolic compartment. The ileum, on the other hand, is the third part of the small intestine, and it will end at the ileocecal junction. That's the union of the terminal ileum with the cecum of the large colon. Most of the ileum lies in the right lower quadrant, also in the infracolic compartment. The terminal ileum usually lies in the pelvis from which it ascends. Recall that mesenteries serve as conduits for nerves, arteries, veins, and lymphatics to and from the organ and the abdominal wall. The mesentery is the mesentery that suspends the small intestine in the abdominal cavity. Its origin or root is directed obliquely and inferior to the right, and it extends from the duodenojejunal junction on the left side of vertebra L2. The root of the mesentery crosses successively the ascending and inferior parts of the duodenum, the abdominal aorta and IVC, the right ureter, the right psoas muscle, and the right testicular or ovarian vessels. Again, between the layers of the mesentery are mesenteric vessels, lymph nodes, and a variable amount of fat as well as autonomic nerves. The vascular supply of the jejunum and the ileum are different from that of the duodenum. These structures are considered to be part of the midgut and therefore are supplied by the superior mesenteric artery. They are supplied via jejunal and ileal arteries or branches off this SMA. Here's the superior mesenteric artery with jejunal and ileal branches. The SMA also gives rise to an ileal branch and an ileocholic artery. The ileal branch gives rise to the appendicular artery, which in turn will give rise to anterior and posterior cecal branches. Near the loops of the bowel, the arteries, near the loops of the small intestine, the arteries form arterial arcades, which give rise to straight arteries or vasa recta that supply the tissue itself. The superior mesenteric vein drains the jejunum and ileum, and as you recall, it will unite with the splenic vein to form the hepatic portal vein. Here it is below, draining the ileum and jejunum. The lymphatic drainage of jejunum and ileum is also complex. It begins with specialized lymphatic vessels in the intestinal villi known as lacteals. Lacteals empty their lymphatic fluid into lymphatic plexuses in the walls of the jejunum and ileum, and they drain in turn into lymphatic vessels between the layers of the mesentery. Within the mesentery, lymph passes sequentially to three groups of lymph nodes. These include the juxta-intestinal nodes, or those that are close to the intestinal wall. Here they are on the right. The mesenteric lymph nodes, scattered among the arterial arcades, and the superior central nodes. These are located along the proximal part of the superior mesenteric artery. These efferent vessels deriving from these nodes drain into the superior mesenteric lymph nodes, and the vessels flow from the terminal ileum, follow the ileal branch of the ileocholic artery to the ileocholic nodes. The jejunum and ileum, like the duodenum, receive both parasympathetic and sympathetic nerve supply. And as usual, fibers course along the arterial pathways. The parasympathetic fibers are from the posterior vagal trunks. Stimulation increases peristaltic activity and secretory activity of the intestine, restoring the digestive processes following a sympathetic reaction. Sympathetic innervation is received from the IML in the regions T8 through T10 segments of the spinal cord. Fibers reach the superior mesenteric nerve through sympathetic trunks and thoraco-abdominopelvic splanchnic nerves, the greater, the lesser, and least nerves, and are associated with the celiac and superior mesenteric ganglion. The post-sympathetic fiber leaves the ganglion and then goes to innervate the target organ. Sympathetic stimulation reduces peristalsis and secretory activity of the intestine and acts as a vasoconstrictor, reducing or stopping digestion and making blood available for the fight or flight reflex. The intestine in general is insensitive to pain, most pain stimuli, including cutting and burning. However, it is sensitive to distension, and distension may produce abdominal cramps or discomfort. Remember, our sympathetics, shown here at the right, leave the IML and they go through the anterior rootlets to the anterior root, and they enter the sympathetic chain through the white communicante, and then they would leave through the splanchnic nerve, going to the celiac or superior mesenteric ganglion and to the target organ. The next part of the gut tube is the large intestine, and it consists of the cecum with its variform appendix, the ascending colon, the hepatic or right colic flexure, the transverse colon, which can have a variable position, the left colic or splenic flexure, the descending colon, the sigmoid colon, and the rectum with the anal canal. It has several distinguishing features, including epiploic appendages. These are also known as omental appendages. They are small, fatty-like omental projections. Tinea coli are also observed on the walls of this thick tube. There are three of them: the mesocolic tinea, the omental tinea, and the free tinea. These three distinct bands of smooth muscle all begin at the appendix, and they run the length of the large intestine. The mesocolic tinea goes across the transverse and sigmoid colons to which it attaches. The omental tinea is to which the omental appendices attach, and the free tinea does not have an attachment for either the mesocolons or the omental appendages. There are also haustra. Haustras are saculations in the wall of the colon that are produced between tinea. The colon also has a greater diameter than that of the small intestine. The cecum is the first part of the large intestine. It is really a blind intestinal pouch. It has two openings, the opening from the appendix as well as the opening from the ileocecal valve. The mesoappendix or variform appendix is a blind-ended diverticulum that enters into the cecum. It contains masses of lymphoid tissue, and it arises from the posterior medial aspect of the cecum to the inferior of the ileocecal junction. It has a short mesentery or mesoappendix, and its position is variable, but usually it is retrocecal. Notice the barium X-rays in the lower part of the image at the right. This is a single contrast barium film in the anterior view versus a double contrast study in the anterior view. Double contrast uses barium and a substance that creates gas when exposed to the heat of the body. It gives more contrast for us to see more detail. Cecum, ascending colon, hepatic flexure, transverse colon with haustra, splenic flexure, descending colon, sigmoid colon, and rectum. Let's look at the cecum from the inside. It is commonly bound to the lateral abdominal wall by one or more cecal folds of peritoneum. The terminal ileum enters the cecum on its inner surface. It actually invaginates, forming an ileocecal valve. The ileocecal orifice forms between the ileocecal lips of the valve or fold. The papilla serve as a reflective passive flap to the valve. This prevents reflux from the cecum into the ileum as contractions occur to propel the contents up through the ascending colon and into the transverse colon. Here you see a better image of the ileal papilla and the ileal orifice. Here's the opening to the appendix. As we've already mentioned, the colon has regions to it. It has the cecum and ascending colon, the right hepatic flexure, transverse colon, left colon flexure or left splenic flexure, descending colon, sigmoid colon, and the rectum with the anal canal. The ascending colon passes up superiorly on the right side of the abdominal cavity, and it is secondarily retroperitoneal, and therefore on its lateral aspect it has a right paracolic gutter. The right hepatic flexure, or the right colic flexure, is deep to ribs 9 and 10. It is overlapped by the inferior part of the liver. And the transverse colon is the most mobile part of the entire large intestine. It has its own mesentery, the transverse mesocolon, and therefore can loop down, often inferior to the level of the iliac crest. The mesentery is adherent to or fused with the posterior wall or the root of the transverse mesocolon of the omental bursa. The left colic flexure or the splenic colic flexure lies anterior and inferior to the left kidney. It attaches to the diaphragm through the phrenicocolic ligament. Then we have the descending portion, which is also retroperitoneal, and because of its peritoneal covering, it creates lateral to it a left paracolic gutter. The sigmoid colon is S-shaped, and it can be of variable length. It is the termination of the tena coli, actually approximately 15 centimeters from the anus. This indicates the rectosigmoid junction. It also has a long mesentery, the sigmoid mesocolon, and therefore it has a considerable amount of movement. Lastly, we have the rectum and the anal canal. The rectum is primarily fixed retroperitoneal and subperitoneal. It is continuous with the anal canal. The gross anatomy of the anal canal is such that we have anal columns, we have a pectinate line, which really is with reference to development, where the upper third and upper 2/3 and the lower third of the anal canal are divided. Developmentally, this represents the hindgut from the proctodeum. Proctodeum derivatives being below the pectinate line or inferior to it. The anus also has an external sphincter muscle and an internal sphincter muscle, and a wide variety of veins that can become engorged and cause hemorrhoidal veins. It also has flaps throughout the canal that serve as rectal valves. The large intestine has a portion derived from the midgut, and then the remaining 2/3 from the hindgut, and therefore is supplied by both the superior mesenteric and the inferior mesenteric arteries respectively. The superior mesenteric gives rise to an ileocolic branch, a right colic artery that it will anastomose with, as well as a middle colic branch. The middle colic will in part continue superiorly and across part of the transverse colon. The inferior mesenteric will give rise to the left colic, which will anastomose with sigmoidal branches, and a final terminal branch, the superior rectal artery. These branches from the superior mesenteric artery and the inferior mesenteric artery all anastomose along the border of the large intestine, forming a large marginal artery. This artery is known as the marginal artery of Drummond, after the individual who first described it. The marginal artery will give rise to arcades and straight arteries supplying the gut tube. Again, the venous circulation is through the hepatoporic vein. That is formed with the union of the splenic vein and the superior mesenteric. Let's look at the splenic vein first. It receives the inferior mesenteric vein, which drains the rectum in part, the sigmoid colon, and the descending colon and the left colic flexure. So, the splenic vein will receive the inferior mesenteric vein, and its feeders include the superior rectal, the rectal sigmoidal veins, and the left colic veins. The superior mesenteric will merge with the splenic to form the hepatic portal vein. The superior mesenteric will receive the cecal veins and ileocolic veins from the right colic and the middle colic. The lymphatic drainage of the large intestine or colon is quite complex, and it begins with pericolic nodes that surround the border of the gut tube. Here in the cecum, nodes pass in the mesoappendix to ileocolic lymph nodes around the ileocolic artery, and then to superior mesenteric nodes. In the ascending colon, drainage passes first to epicolic and pericolic lymph nodes, and then through the ileocolic and right colic nodes, and then to the superior mesenteric lymph nodes. Pericolic nodes drain into middle colic nodes for the transverse colon, and then again into the superior mesenteric lymph nodes. Descending colon is a little bit different. Again, beginning with the epiplog and the pericolic nodes, draining into the left colic nodes and to the inferior mesenteric lymph nodes. The rectum has a lymph drainage that's differential, depending upon if you are above or below the pectinate line. If you're below the pectinate line, drainage is into superficial inguinal nodes. If you are above the pectinate line, drainage begins through the superior rectal nodes, and then the internal iliac nodes. The nerve supply of the colon is also complex. For the most part, in the cecum, the appendix, the ascending colon, and transverse colon, the sympathetic supply is received from the superior mesenteric plexus, and the parasympathetic nerve supply from the vagus nerves. For the descending colon and sigmoid colon, this is a little bit different, as well as for the rectum. In the sigmoid colon and descending colon, sympathetics come from the sympathetic trunk, but via the abdominopelvic splanchnic nerves. And parasympathetics come from the pelvic splanchnic nerves via the inferior hypogastric plexus. Here's our our parasympathetic component, the inferior hypogastric plexus, or pelvic splanchnics, and our superior hypogastric plexus, which contributes to sympathetic components. In terms of the rectum, again, the division is between if you are above or below the pectinate line. Above the pectinate line, nerve supply is visceral, coming from the inferior hypogastric plexus. If you're below the pectinate line, then innervation is somatic, being supplied by the inferior rectal nerves, which are branches of the pudendal nerve. Now we are going to turn our attention from the gut tube to some of the accessory organs, and the first organ we're going to look at is the spleen. It is located in the left upper quadrant near the hypochondrium. And of all the lymphatic organs, it is the largest one. It is not really part of the digestive system, but is part of the lymphatic system. And it has several anatomical relationships. For example, anteriorly, it is associated with the gastrosplenic ligament. Posteriorly, the left part of the diaphragm, inferiorly, the left colon flexure, and medially, the kidney, the left kidney, via the splenorenal ligament. It also has surfaces and borders. Its diaphragmatic surface is convex. Its medial surface has a hilum that's not covered by visceral peritoneum, and it has borders. It has the posterior, the anterior, and the superior borders. Okay? Some of these appear notched or rounded. Here's a picture of the spleen in the left upper quadrant, its relationship with the liver and diaphragm, the kidney, and part of the pancreas. The vascular supply of the spleen is relatively simple. Again, this is an organ that is derived from the foregut, so it is supplied by the celiac artery, and actually its primary branch is the splenic artery that arises from the celiac trunk. In fact, the splenic artery is the largest branch of the celiac trunk. So let's look at our diagram. Here's the celiac trunk, here's the splenic artery, and it courses posterior to the omental bursa and on the dorsal surface of the pancreas, and it continues laterally till it reaches the hilum of the spleen, and then it's going to branch, and it will give rise to a right gastro-omental epiploic artery, okay, and splenic branches that go into the hilum of the spleen. But also throughout its course, the splenic artery gives rise to a number of branches in the layers of the splenorenal ligament that also feed the pancreas. Then the venous circulation is also through the splenic vein, which has various tributaries, not only from the pancreas, but also tributary from the right gastroepiploic vein. And it's joined by the inferior mesenteric vein before it feeds, or unites, I should say, with the superior mesenteric vein, becoming the hepatic portal vein. Lymph drainage of the spleen is relatively simple. It begins at lymph nodes located in the splenic hilum, and this lymph passes along to vessels and the pancreatico-splenic lymph nodes. This is en route to the celiac nodes around the celiac trunk. Innervation of the spleen is provided by the celiac plexus. So this is a sympathetic plexus or ganglion, and it mainly distributes the branches to the spleen as well as the pancreas. And these are vasomotor in function. The parasympathetic innervation, again, comes from the vagal tone, but the function there is not quite clear. The pancreas is both a digestive gland and an endocrine gland. It sits elongated retroperitoneally, overlying and crossing transversely the bodies of the L1 and L2 vertebrae in the level of the transthoracic plane. So it goes along the posterior abdominal wall. As such, it lies posterior to the stomach, and the duodenum wraps around part of the pancreas, that portion known as the head. The transverse mesocolon also attaches to its anterior margin. Again, it has a head that's an expanded part that is really cupped by the duodenum, and it rests posterior on the IVC, or the inferior vena cava, the renal artery and vein, and the left renal vein. It has an uncinate process hidden in the middle diagram, which is a projection from the inferior part of the pancreatic head, and it extends medially to the left, posterior to the superior mesenteric artery. Then it has a neck. The neck overlies the superior mesenteric vessels, which form a groove on its posterior surface. Here, the superior mesenteric vein joins with the splenic vein posterior to the neck to form the hepatic portal vein. And we have the body, which continues from the neck, and it lies to the left of the superior mesenteric vessels, passing over the aorta, as well as L2, and it continues to just above the transpyloric plane, posterior to the mental bursa, and it ends just before it gets to the spleen, where the pancreas then becomes the tail, and it lies anterior to the left kidney in close relationship with the splenic hilum. It is relatively mobile and passes between the layers of the splenorenal ligament and the splenic vessels. The spleen has a main pancreatic duct that extends from the tail, runs through the parenchyma of the gland or the body and the neck, and near to the head. The main pancreatic duct and the bile duct usually unite to form a short dilated hepatopancreatic ampulla, or the ampulla of Vater. Here it opens into the descending part of the duodenum. 25% of the time the duct opens into the duodenum separately. The sphincters of the pancreatic duct really surround the terminal part of the pancreatic duct, and the sphincter of the bile duct surrounds the termination of the bile duct, and the hepatopancreatic sphincter of Oddi around the hepatopancreatic ampulla. There's also an accessory pancreatic duct. It opens into the duodenum at the summit of the minor duodenal papilla. It communicates with the main pancreatic duct as well. The arterial supply of the pancreas really comes from the splenic artery, or its main supply, which gives rise to several pancreatic branches, as well as pancreatic branches from the pancreaticoduodenal arteries and the superior mesenteric arteries. Of course, there are the corresponding pancreatic veins, which are tributaries to the splenic vein and the superior mesenteric vein. These will unite to form the hepatic portal vein. The lymphatics and nerves of the pancreas also follow the blood vessels. Most vessels end in the pancreatico-splenic lymph nodes. Some end in pyloric lymph nodes, and the efferent vessels from each of these sets of nodes drain into the superior mesenteric lymph nodes. Innervation is both parasympathetic from the vagus nerve and sympathetic from abdominopelvic splanchnic nerves. The parasympathetic sympathetic fibers reach the pancreas by passing along the arteries from the celiac plexus and the superior mesenteric plexus. Fibers pass along with blood vessels, and even the acinar cells have sympathetic and parasympathetic innervation. Sympathetic from the sympathetic chain ganglion, parasympathetic from the vagus nerve. The last of the abdominal viscera that we are going to discuss include the liver and the gallbladder. And of course, the liver is the largest gland in the body, and it resides in the right upper quadrant. It has a diaphragmatic surface that is smooth and domed, and is responsible for the elevated dome of the diaphragm on the right side of the body. It also has a subphrenic recess. It is separated into left and right by the falciform ligament. The subhepatic space is in the subcolic compartment of the peritoneal cavity, immediately inferior to the liver. There is also a hepatorenal recess or hepatorenal pouch. It is also known as Morrison's pouch after the person who discovered it. This is a posterior superior extension of the subhepatic space lying between the right part of the visceral surface of the liver and the right kidney and suprarenal gland. Fluid can collect in this hepatorenal recess or Morrison's pouch. Again, the diaphragmatic surface of the liver is smooth and rounded up. It projects into the right dome of the diaphragm. It constitutes the bare area of the liver in part. The bare area is demarcated by reflections of the peritoneum from the diaphragm to its anterior superior and posterior or lower layers of the coronary ligament. Here's the coronary ligament. These layers meet on the right to form the right triangular ligament, and they diverge to the left to enclose the triangular bare area. The anterior layer of the coronary ligament is continuous with the left and right layers of the falciform ligament. The posterior layer is continuous with the right layer of the lesser omentum. Near the apex of the wedge-shaped liver, the anterior and posterior layers of the left part of the coronary ligament meet to form the left triangular ligament. The inferior vena cava traverses a deep groove within the bare area of the liver. Its visceral surface is covered with visceral peritoneum except for the fossa of the gallbladder, the porta hepatis, and the transverse fissure where the vessels, the hepatic vein, artery, and bile duct pass, as well as the nerve plexus. Sagittally, there's a right fissure and a left fissure. Here's the right fissure and the left fissure. And they're connected on the visceral surface in a letter that's shaped like the letter H. The round ligament of the liver, or ligamentum teres hepatis, is the fibrous remnant of the umbilical vein and is along the free edge of the falciform ligament. Ligamentum venosum is the fibrous remnant of the fetal ductus venosus, which shunted the blood from the umbilical vein to the inferior vena cava, short-circuiting the liver. Here's ligamentum venosum, a remnant of the ductus venosus. The lesser omentum encloses the portal triad, here shown on the diagram at the right. It consists of the bile duct, the hepatic artery, as well as the portal vein. The thick free edge of the lesser omentum extends between the porta hepatis and the duct and the duodenum. This is called the hepatoduodenal ligament. It encloses the structures that pass through the porta hepatis. The remainder of the sheet-like lesser omentum is the hepatogastric ligament. It extends between the groove for the ligamentum venosum and the lesser curvature of the stomach. There are also some additional relationships that the physician should be aware. Of course, the gastric and pyloric areas of the stomach reach the right side of the liver in the anterior aspect. And the duodenal area of the liver is there for the superior part of the duodenum. The lesser omentum and the ligamentum venosum, as well as the fossa for the gallbladder, we've already discussed. We haven't mentioned the right colic flexure and the right transverse colon or colic area. It also reaches up to the right lobe of the liver, as well as a space, a renal area, for that of the right kidney and adrenal gland. And of course the lobes. We have the right and left lobes. We have the quadrate lobe, which is anterior, and the caudate lobe, which is posterior. This is a lot of words here to explain hepatic surgical segments of the liver. For you as a first-year medical student, it's enough for you to know that the liver lobes are divided into segments that are each supplied by a vein, an artery, as well as a duct that leads to the bile duct. Therefore, each segment is surgically resectable. Now let's turn our attention to the gallbladder, where a system of biliary ducts convey bile from the hepatic parenchyma to the sac-like structure and eventually to the duodenum. The bile is stored and concentrated in the gallbladder, and the gallbladder, seen here in its bed or fossa on the inferior side of the liver, has a fundus, it has a body, and it also has a neck leading to a cystic duct. Canaliculi drain into small interlobar biliary ducts and then into large connecting ducts. These ducts merge to help form the hepatic ducts. The left and right hepatic ducts come together, forming a common hepatic duct to which the cystic duct joins into. This then forms the common bile duct. Because the liver and gallbladder are viscera of the foregut, they are supplied by the ciliary trunk. The ciliary trunk is seen here, and it gives rise to the splenic artery as well as a common hepatic artery. And the common hepatic will divide into the proper, and the proper will give rise to left and right hepatic arteries, and usually the cystic artery arises from the right hepatic artery, although this can be considerably variable. 3 veins drain the liver: the right vein, the intermediate vein, and the left hepatic vein. Here's the right hepatic vein, the middle hepatic vein, and the left hepatic vein. And again, they're all associated with specific surgical segments of the liver. The hepatic veins are formed by the union of veins or collecting veins that in turn drain the central veins of the hepatic tissue, and they open into the inferior vena cava just inferior to the diaphragm. The venous drainage of the gallbladder is a little bit different. There's drainage from the neck of the gallbladder on the cystic duct that flows via cystic veins. These veins eventually join the veins draining hepatic ducts and the proximal bile ducts. Veins from the fundus and body of the gallbladder, in contrast, pass directly to the visceral surface of the liver and drain into the hepatic sinusoids. Lastly, venous drainage from the proximal part of the bile duct and the hepatic duct usually enters the liver directly. The posterior superior pancreatico-duodenal vein drains the distal part of the bile duct and will empty into the hepatic portal vein or one of its tributaries. Now let's look at the lymphatics and nerves of the liver. Then we'll do the same for the gallbladder, and we'll be ready to move on to some clinical correlations. With respect to the lymphatics of the liver, there are superficial and deep lymphatics. The superficial lymphatics are in the subperitoneal fibrous capsule or Gleason's capsule. The deep lymphatics are in the connective tissue, which accompany those structures of the portal triad and hepatic veins. Superficial lymphatics from the anterior aspect of the diaphragm and visceral surfaces of the liver, as well as the deep vessels accompanying the portal triads, converge toward the portus hepatis. Superficial lymphatics from the posterior aspects of the diaphragm, visceral surfaces of the liver, also drain into the bare area of the liver. From the posterior surface of the left lobe, the liver drains toward the esophageal hiatus of the diaphragm to end in the left gastric lymph nodes. Also, the anterior central diaphragmatic surface along the falciform ligament drains into peristernal nodes. Finally, along the round ligament of the liver to the umbilicus and the lymphatics of the anterior abdominal wall. Innervation, of course, is derived from the celiac plexus that has both sympathetic and parasympathetic fibers running through it. The parasympathetic fibers arise from the anterior and posterior vagal trunks. Nerve fibers also accompany vessels and biliary ducts along the portal triad. Other than vasoconstriction, their function is unclear. With reference to the gallbladder, lymphatic vessels and nodes include the cystic lymph nodes near the neck of the gallbladder, and the lymph nodes of the omental foramen and hepatic lymph nodes. Efferent lymph vessels move along the bile duct passageway to the celiac lymph nodes. Innervation, of course, is from the celiac nerve plexus, which provides both sympathetic and parasympathetic fibers, parasympathetics being from the vagus nerve. And the right phrenic nerve actually offers some somatic fiber components, actually somatic afferent or sensory fibers. Parasympathetic stimulation results in contraction of the gallbladder and relaxation of the sphincters at the hepatopancreatic ampulla. We should talk more about one item because it is important to anatomy and your knowledge of clinical correlates. And these are the tributaries of the hepatic portal vein, more specifically the portal systemic anastomoses. These are pathways of communication between the portal venous system and the systemic venous system, and they are formed within the submucosa of the inferior esophagus, the submucosa of the anal canal, the peri-umbilical region, and the posterior aspects of the bare area of the liver, which are secondarily retroperitoneal. There's also an area within the colon of retroperitoneal veins. When the portal circulation through the liver is diminished or blocked, these then act as collaterals, returning venous blood to the vena cava. Depending upon which alternate anastomotic pathway is being used, secondary to where blockage has occurred, the patient will present with different signs and symptoms. The clinical correlations required by the university for discussion include hiatal hernia, small bowel obstruction, intestinal ischemia, appendicitis, and diverticulosis. Here I've added for completeness cholelithasis or gallstones and the signs that you would see regarding blockage of the portal system and secondary use of the portal systemic anastomoses. These include esophageal varices, caput medusae, and hemorrhoids. In a prior lecture, we discussed hiatal hernia. This is where there's a protrusion of part of the stomach and perhaps other abdominal viscera into the thorax through the esophageal hiatus. This can be a congenital diaphragmatic hernia, or CDH. This is where the opening between the pleural and peritoneal cavities, or the pleural peritoneal canal, fails to fuse during development. This allows the gut viscera to herniate upward into the thorax, causing compression of the lungs and hypoplasia. CDH is in contrast to ADH, or acquired diaphragmatic hernia, which is usually the result of blunt or penetrating injury. Surgery on the abdomen or chest may also cause incidental damage to the diaphragm. Also, this can result from spinal deformity, such as kyphosis or scoliosis or kyphoscoliosis, leading to a weakening of the diaphragmatic slinging mechanism, therefore allowing the abdominal viscera to protrude upward. Structures that pass through the esophageal hiatus may also be damaged in these situations and include the vagal trunks, the left and right inferior phrenic vessels, the esophageal branches of the left gastric vessels. These also may be injured during surgical repair of hiatal hernia. Small bowel obstruction, or SBO, can be caused by a variety of pathological processes. Sometimes it's just a loop of bowel that presses through a rent or tear in the mesentery. Other times, the diagnosis is a post-operative adhesion. This is probably the most frequent cause, followed by malignancies, Crohn's disease, and other hernias. Obstruction can be characterized as either partial or complete versus simple or strangulated. Further, abdominal pain is also described as crampy or intermittent. Pain that occurs for a short duration of time and is colically and is accompanied by bilious vomiting may be more proximal. However, pain that lasts as long as several days or is progressive in nature may be accompanied by abdominal distension and may be typical of more distal obstruction. The signs and symptoms a patient usually presents with include nausea and vomiting, diarrhea or constipation, diarrhea as an early finding, constipation as a late finding due to the absence of flatus or bowel movements, and fever and tachycardia. Previous abdominal or pelvic surgery might be noted in the patient's medical history, as well as previous radiation therapy. There may be a history of malignancy or ovarian or colonic malignancy. Here in the image to the right, we see the dilated loops of small bowel secondary to obstruction. Intestinal ischemia is the result of occlusion of a vessel. This could be the vasa recta, or it might be one of the larger vessels, such as the one shown here at the right, the occlusion of the superior mesenteric artery. Blockage occurs here, indicated by the laser pointer. Blockage can be from a blood clot or any kind of embolus, a fat embolus, even an air embolus. And if the ischemia is severe, necrosis or tissue death will be the result. And ileus, or obstruction of the intestine, is really a paralytic type of obstruction. Ileus is the specific term we refer to the intestine where the paralytic type has occurred. So ileus is accompanied by severe pain, along with abdominal distension, vomiting, and often fever and dehydration. If the condition is diagnosed early, such as on the right here, with an angiogram, in this case a SMA angiogram, the obstruction of the vessel may be cleared surgically, restoring blood flow and saving the piece of tissue. Appendicitis is an inflammation of the appendix. You can see an inflamed appendix at the right. In young people, it's usually the cause of hyperplasia of the lymphatic follicles that then occlude the appendicular lumen. In older people, it usually results from a fecal lith, which is a concretion that forms around a center of fecal matter. Signs and symptoms include pain caused by digital pressure over McBurney's point, also referred pain, and pain of appendicitis usually commences with vague pain in the periumbilical region. Later, severe pain presents in the lower right quadrant. Acute infection of the appendix may result in thrombosis or blood clotting in the appendicular artery, which then results in ischemia and gangrene, as well as perforation of the inflamed appendix. Rupture of an appendix results in infection of the peritoneum or peritonitis. Treatment is appendectomy. Diverticulosis is a colon disorder in which there are multiple pouches or evaginations, outpocketings of the mucosa of the colon. These develop along the intestine. Here you can see them at the right. Occasionally, the diverticula are subject to infection and rupture, leading to diverticulitis, shown here on the right. Diets high in fiber have proven to be beneficial in reducing the occurrence of diverticulosis, in that fiber diets help push the fecal matter along. We can map referred abdominal pain to specific regions of the gut. In the foregut, the organs of the stomach, the duodenum, the liver, and the gallbladder give referred pain to the upper abdomen or the epigastric region. This is in contrast to the spleen and pancreas, which send referred pain information to the epigastric region, the left hypochondriac, and the mid-back in the case of the pancreas. For the midgut, the organs include the small intestine, the appendix, and the right colon, and the site of referred pain is the mid-abdomen. This is in contrast to the hindgut, where the organs considered are the transverse colon, the descending colon, the sigmoid colon and rectum, and the site for referred pain is the hypogastric region or the lower abdomen. Cholestasis is the medical term for gallstone disease, and here at the right, you see the result of a cholecystectomy or surgical procedure to remove the gallbladder filled with gallstones. A gallstone is a concretion in the gallbladder cystic duct, or it could be anywhere in the bile duct system. They are chiefly composed of cholesterol crystals. They are more common in females. They also increase with age, or the incidence increases with age, and 50% of persons with gallstones are silent or asymptomatic. For gallstones to cause clinical symptoms, they must obtain a size sufficient to produce a mechanical injury to the gallbladder or to produce an obstruction of the biliary tract. We've already spoken about the sites of portal caval anastomoses. And depending upon which site is used or engorged secondary to blockage of the portal system, different signs and symptoms may be produced. For example, if the site of anastomosis used is the esophagus, esophageal varicoceles can be seen. Here, using a barium swallow. Around the umbilicus, the dilated veins produce caput medusae. And the anastomosis between the superior rectal vein and the middle and inferior rectal veins produces hemorrhoids when engorged. Concluding now with our clinical scenario, as you recall, we had a 53-year-old African American male patient that presents to your office with a chief complaint of abdominal pain. You order the radiograph shown here, CT scan, and a reconstruction. You would most likely expect the clinical presentation of this patient to include, and here are your choices: left or right testicular varicocele, fever, abdominal pain, abdominal tenderness, frequent and forceful bowel movements. All these are signs of intestinal ischemia. Caput medusae, decreased blood flow to the right kidney, and hypertension. And the correct answer would be the left testicular varicocele, because here we have an aneurysm in the superior mesenteric artery, and the left renal vein courses directly underneath it. The aneurysm causes compression of the venous return from the left gonadal vein, which joins the left renal vein, and the patient presents with testicular varicocele. In the laboratory, you're going to be dissecting the gut tube in vivo, and then detaching the gut tube from the peritoneum and removing the gut tube from esophagus to the superior rectum by cutting the celiac trunk, the superior and inferior mesenteric arteries. You'll continue this dissection in a tray, and part of your team will continue to dissect the accessory organs, the liver, the spleen, gallbladder, and pancreas. By the end of the laboratory period, you should be able to identify the abdominal organs and understand the relationships in situ and distinguish parietal from visceral peritoneum, intraperitoneal from retroperitoneal organs, as well as identify peritoneal reflections and folds, mesenteries, and recesses. You should be able to identify the celiac trunk, the superior and inferior mesenteric arteries, and verify their distributions and branches to the abdominal viscera. You should be able to identify the viscera draining into the portal venous system and the named vessels making up this system. The student should also be able to identify the component parts of the foregut, midgut, and hindgut, including their neurovascular supply and lymphatic drainage. You should be able to identify major abdominal organs in medical imaging studies, including plain film X-ray, computed tomography, MRI, and ultrasound. And finally, we always expect that you demonstrate professionalism by working cooperatively in the small group setting. This concludes this presentation.